the IASLC. It's a pleasure to welcome all of you to our first press conference of the 2019 World Conference on Lung Cancer. It's our 20th WCLC, and I'm delighted to just share with this smaller audience right now, but our registration numbers are approaching 7,700, which is a record for us, which we're very excited about, and we're represented right now from 107 different countries here at the WCLC, which is also a high water mark for us. So we're very excited about that. And I think what that is a testament to is clearly the interest in lung cancer and other thoracic malignancies, and it certainly speaks to the quality of the program and the interest and also the quality of the speakers that we have here, not only today, but at our other press conferences and throughout the conference. So I invite all of you to come to all of our press conferences, as we'll be talking about and highlighting all of the interesting developments that are going on over the next several days. I guess just one ground rule before we jump into it, I would just ask that we hold questions until the very end, and then we're going to open it up to all of our panelists to take your questions. But with that, welcome to our panelists, and to kick us off, I'd like to invite Dr. Rami-Porta and Dr. Rosell to the podium here. They are our conference presidents. Also joined, Enriqueta Philippe is another one, but couldn't make it. But I invite you up to share some of the highlights and the interest and the excitement.
Ladies and gentlemen, on behalf of Dr. Enriqueta Philippe and Tony Rosell, we would like to welcome you to Boston and to the 20th World Conference on Lung Cancer. We have divided the different tracks among ourselves, and Tony and I will cover Dr. Philippe's slides. We'll try to give you what we think are the highlights of this meeting. Okay, I'm sorry. It works now. Maybe here. Nothing to declare. Here. Okay. Regarding the treatment of early-stage lung cancer, there will be 2 randomized clinical trials comparing the minimally invasive approach with a classic thoracotomy. Now, these are important studies because we have been practicing VATS resections, video-assisted thoracoscopic resections, for at least 2 decades without a proper study, with properly designed clinical trials. Now we have 2, and we don't know the results of the first one, which comes from the UK. It will be presented in the presidential session. The other one comes from China, and we think that the results of these trials will change the mind of many thoracic surgeons who still are resistant to practice video-assisted thoracoscopic surgery for lobectomy to resect lung cancer. There are not so many surgical trials, so I think this is an important thing that these are presented here at the World Conference. Regarding staging, you probably know that staging is one of the pillars of the Scientific Academy of the IASLC. So we have been collecting data from around the world to revise and improve the TNM classification of lung cancer. That's the anatomic extent classification based on the tumor, primary tumor, lymph nodes, metastasis. And we will analyze certain aspects of the data set that we are using now to collect cases for the 9th edition, which is due to be published in 2024. And lymphadenectomy, you see here, both in the first study and the second study, is of paramount importance. We have to stage the tumors before treatment, knowing whether there are lymph nodes involved or not, but also the intraoperative assessment of the lymph nodes at lung resection is important to stage the tumor properly so that we can make therapeutic decisions after resection in terms of indication of adjuvant therapy, for example, or in terms of prognosis. The N factor gives us a shade of the prognosis. Finally, oligometastasis. was one of the jewels of the crown last year in Toronto. There were many presentations. The oligometastatic disease is getting more attention because now we know that if we select patients well and if we can treat radically both the primary site and the metastatic site or sites, prognosis is much better. Anything that we can obtain over a 0% mortality, which is what stage 4 has, at least the clinical staging, is an achievement. And we can achieve much more than that by applying local therapies both to the primary tumor and the metastatic sites. In the treatment in the real world, well, it's evident that not all thoracic oncologists or surgeons have the same facilities in their institutions. So these are sessions that will inform us about the difficulties that some of our colleagues have in getting patients with lung cancer in early stage, for example. My colleagues in certain countries tell us, well, we only see advanced disease, malignant pleural effusion, so that the resection rate is very low. So all this will be discussed here together with the patient-reported outcomes. You know, physicians study the disease from the scientific point of view, but it's also important to know what's the feeling of the patient regarding their illness. You know, they have different perceptions on the disease and also on the diagnostic tests and therapies. Regarding our colleagues in nursing and allied health professionals, you will see if you attend these sessions that nurses can do much more than the topic work that they do in the wards. They can really assist the oncologists and the thoracic surgeons taking care of some activities in the outpatient clinic, in follow-up, in taking care of the wounds postoperatively, and so on. I think it's really relevant that the nurses have many sessions in this conference, and also they have sessions in other tracks. Conquering thoracic cancers worldwide. Lung cancer is not the only neoplasia that is dealt with by the ISLC. We also have thymoma and other thoracic malignancies and mesothelioma. Now we will have presentations on novel biomarkers. Biomarkers have been studied more in lung cancer, but also in mesothelioma and thymic tumors. They are very well studied, or they are beginning to be studied better. Chest wall tumors are rare tumors, but they may pose difficult therapeutic problems. And there will be 2 sessions, one on chest tumors proper and the other one on tumors of the sternum, very rare but sometimes difficult to treat. Regarding mesothelioma, we will have novel molecular markers and a very good update on the ongoing trials on therapy. So regarding this set of tracks, first the randomized clinical trials, really important. They will change clinical practice. The relevance of the ISLC database for the staging project. The importance also of the nurses in cooperating with the treatment and follow-up of the patients, increase awareness of patient-reported outcomes, and also the combined therapies in all thoracic malignancies, lung cancer, thymic tumors, and mesothelioma. Disclosures from Enriqueta. Targeted therapies, also this was the jewel of the crown last year, but we are following with the topic because both targeted therapies and immunotherapies are the research lines that have changed therapy and also prognosis in advanced cases especially. We'll have the first study is a drug to treat red fusion positive lung cancers. A small percentage of the cancers have red fusion, but we have now a drug that seems to be effective to treat this lung cancer. And then we have this umbrella phase 2 trial analyzing a molecular therapy based on the type of molecular alteration that the tumors have. And then 2 studies regarding KRAS. For KRAS, there was no therapy, right? Now we start having therapies for KRAS, KRAS in the form of drug, but the last study, the last line, is the chimeric antigen receptor T cells that have already been used and are already being used in hematological malignancies, and now they may be effective to treat lung cancers with KRAS mutations. Immuno-oncology, 2 trials looking at tumor TMB, tumor mutation burden, that will emphasize the importance on the outcomes on the tumor mutation burden. Also, the mutations associated with the sensitivity or resistant to immunotherapy. You know that the tumors have the capacity to become resistant both to chemotherapy, targeted therapies, but also to immunotherapy. And this trial will analyze this. And we will also have a combination of immunotherapy for subgroup of patients, patients with a poor performance status and other subgroups of patients. And finally, at the end results of the IMpower 131 that will give the final results of this study. I think this is yours, so thank you very much.
Already. Oh, okay. Yeah, I was just following. That's the best. Yeah. I do it. Look at the pressure. Yeah.